Okay, we're going to get started in just a second. There's attendees still coming in. As soon as I see that slow down, then we'll start our talk, probably just about another minute. All right, we are going to get started. Hi, everyone, and thank you for attending Invita Fertility's patient education webinar on fertility preservation and egg freezing. My name is Vicki, and I'll be your moderator for this informational session. I'm honored to present to you the panelists of our webinar, Dr. Elizabeth Puscheck and guest speaker, Kelly Schorsch. Dr. Puscheck trained at the Washington University Medical School in St. Louis and then completed her fellowship at the Medical College of Georgia. She will be teaching us about fertility preservation and egg freezing. Kelly Schorsch is an embryologist and the lab supervisor at Invita Fertility Specialists. She has worked with Invita for a total of 8 years. She started as an andrologist and moved up to being an embryologist. She has her bachelor's degree in biology with a minor in chemistry and received her master's degree in clinical embryology and andrology from the Eastern Virginia Medical School. She'll be teaching us about what embryologists do in the lab when they are freezing and thawing eggs. Invita Fertility has 3 physicians in total, Dr. Puscheck, who will be talking today, Dr. Karande, and Dr. Klipstein. All 3 of these physicians are board certified in the specialty of obstetrics and gynecology and the subspecialty of reproductive endocrinology and infertility. We also have 4 locations for the convenience of our patients. Our main office is Hoffman Estates. This is where our surgical suite is and where our embryology lab is located. We have satellite offices in Arlington Heights, Crystal Lake, and Northbrook. If you have any questions during this webinar, please type them in the Q&A section and we'll have time at the end for a question and answer segment. Now that you know a little bit about us, we want to know a little bit about you. I'm going to put up a poll and I would ask that, if you could just answer this, where you are in your fertility journey so we can kind of know what our audience is comprised of. I'll just leave it up for a few more seconds. Okay, so I'm going to share these results. It looks like a majority of our attendees are patients of Invita, so that's great. And 1 person has not yet started their journey. So we're really going to kind of explain what's the process of egg freezing and see if maybe that's something that you might be interested in. We'll have other polls during the presentation, and I'd be grateful if you could share your responses with us. Now I'd like to turn this over to Dr. Puscheck to start her segment on egg freezing and fertility preservation.
Good evening. I'm delighted to be here to talk to you about how to preserve your fertility so you can have your family when you're ready to have a family. This picture on the left is of a real egg. Next slide. So egg freezing really had its big breakthrough in technology recently, but the first baby born from egg freezing was back in 1986. Since that time, it wasn't until 2012 that the American Society of Reproductive Medicine felt that the technology was now safe, effective, and efficient enough to take it off of the experimental list. So it is no longer experimental. One of the main reasons that it was taken off the experimental list was because of this new ultra fast freezing technique that's called vitrification. It's like instant glass. And this has really helped in the survival of eggs from the freeze and thaw process. The egg is like a supercell. It has almost like 10 cells within its 1 cell. And so it was much more prone to getting little crystals in it, and that would be a problem during a slow freeze. So with the ultra fast freezing of vitrification, the egg can be instantly frozen, and then it survives the thaw about 90 to 95%. So very high survival rate. Next slide. So since 2012, egg freezing has become much more popular, and we're seeing that rise in trends for elective fertility preservation. Next slide. So why do people freeze their eggs? The one that seems most obvious is if you have a cancer, like a breast cancer or a blood cancer, like a leukemia or lymphoma or sarcoma. Well, those patients really are fast-tracked in our practice. Somebody gets the diagnosis and they want to preserve their fertility, we'll get them in the same day, the next day, within the first couple of days, so they can really move forward with this quickly. But the more common reasons for people to seek elective fertility preservation is with benign conditions or social reasons. The benign conditions may be where you have a medical condition where you may need to take the same chemotherapeutic agent like you take for a cancer, even though you don't have a cancer, and that can certainly happen. And there are other benign diseases such as ovarian tumors where there needs to be some surgery, or endometriosis that may impact your fertility in the future, and you may want to freeze your eggs sooner because that might get worse over time. And some people have a genetic predilection to going through menopause early, such as if they are a carrier for Fragile X disease or Turner's mosaic. And so those individuals may consider it as well. But by far the most common reason is for social reasons. And the main reason for this is that as we age, the eggs have a higher risk of atrophying and going through menopause as you get older. So one reason that people want to freeze their eggs is so they can have childbearing when they want to. Perhaps they lack a partner, or their career choices are more important right now, or financial reasons. And I'm going to show you some more about this in the next couple of slides. Next slide. So a lot of my patients that come and ask for egg freezing will say things like this: I'm not ready to be a mom right now, but I do want to become pregnant when I'm ready. Or I've not found the right partner yet, and I don't want to be a single mom at this time. I might consider being a single mom later though, or maybe I'll find Mr. Right. Others have a medical condition, like I've mentioned, that impact the ovaries, or they may have to take a toxic medicine that would be bad for the eggs, and even if they don't have cancer, so they might want to freeze them for that reason. And of course, the big C, the yellow box here, is if I have cancer, I want to move forward quickly to freeze my eggs so I can have my family in the future. And it actually gives a wonderful sense of hope and peace of mind when you have those eggs frozen for a future family. But keep in mind, it's not a guarantee. And we'll go over those probabilities later in the talk. Next slide. So if we look at the distribution of women coming to see us for elective fertility preservation, over 94% of the time it's because of age. And this is for the non-cancer reasons. Next slide. So what does age do? Well, when we look at this graph, this is a graph of actual data that gets sent from our Society of Reproductive Endocrine, our Society of Assisted Reproductive Technology, or SART, and it also goes to the CDC, where we track the pregnancy rate by age. So the bottom, our x-axis, is age, and the y-axis is the pregnancy rate. And you can see as women get older, that pregnancy rate decreases significantly. The first yellow arrow is pointing out where there's a slight decrease, and that happens around age 30. And then the second arrow shows a much more rapid decrease around age 37. Next slide. So this slide is showing actually a donor egg slide that can show you how freezing your own eggs early can have a similar outcome. So the bottom curve is showing that same graph I just showed you with the age on the bottom and the live birth rate per transfer this time along the y-axis. But you see another curve that's pretty much horizontal, so it's not showing a decrease as age is going on. And this is because when we're using donor eggs, or eggs from somebody who's in their 20s or early 30s, and it doesn't matter what the age is for the uterus that we're putting the eggs in, of course, they're embryos by the time we're transferring them to the uterus, the pregnancy rate is really pretty consistent. So it seems like eggs are really the main factor. So if you freeze your eggs early, you can have a similar live birth rate per transfer if you do your own frozen eggs at age less than 35, and maybe you want to get pregnant at say 40, you'll have that same pregnancy rate as the age you were when the eggs were frozen. Next slide. So the true egg facts here is that age impacts both the egg quantity, the number of eggs you have, and the quality. So we help you when you come see us to assess what your ovarian reserve is. And we do that through a couple of different means. One is an ultrasound, and through an ultrasound, we can measure what's called an antral follicle count. And the antral follicle count is where we look at the ovaries, and in each ovary, there are little follicles which look like little black spots on an ultrasound that we measure that are less than 10 millimeters in size. And when we do that, that gives you an idea of what your ovarian reserve is like. The other thing that we look at is a blood test that measures two different hormones. One is an AMH, or anti-Müllerian hormone, and this kind of gives you an idea of what your quantity of eggs are like. And then the second one is an FSH, which gives you a more indicator of what the quality of your eggs are like. Now keep in mind, the younger you are at the time that you freeze your eggs, the higher the success you're going to have in having a live birth later, even if you're 40. Using younger eggs, it makes a big difference, like I showed you with the donor eggs. Okay, next slide. So when is the best time to freeze your eggs? Well, the earlier the better, but as I showed you on that graph, anytime between the ages of 25 and 35 give us the best ovarian reserve. Of course, if you can do it less than 30, that's even better, but a lot of women aren't even thinking about it by that time. The uterus does not seem to be impacted by age, so we're not so worried about that part of it. But other things that are impacted by age are the pregnancy rate. So the earlier you are, the higher the pregnancy rate when we're freezing eggs younger. You'll also have a lower genetic risk if you freeze them earlier, and a lower miscarriage rate. Now, the inverse is true as you get older. So all are better when you are younger. The other question is, how long can you store these eggs? You can keep them frozen as long as you want to. Next slide. So this is just reiterating the impact of genetic risk on the embryos. And it's basically from the age of the eggs. The age you were at that you had the eggs frozen are going to impact what the genetic composition of the embryo would be like. So if you have, if you're 25 or 30, when you freeze the eggs and then we create the embryos later and transfer them, those eggs are still going to be at the level of a 25 to 30-year-old, even though you may be 40 at this time. So the genetic risk would be about 25%. But if you were looking at freezing eggs when you're 40, then that genetically abnormal rate is going to be closer to 60%. So just to keep that in mind. Better to do this when you're younger. Next slide. So what is involved with eggs freezing? The egg freezing process that we go through to get the eggs is really like an IVF process. And we did an IVF webinar earlier, and if you want to watch that, you can go to our website and it's there for you to take a look at anytime you like. But just to give you a little bit of an overview, what we're doing when we're trying to get the eggs out is we're going to be stimulating you, and we start that around the time that your menstrual cycle starts, and we'll give you medications that are basically consisting of the same hormones that your ovaries would normally respond to have the follicles grow. So these are FSH and LH, and we give them to you in higher doses so we can get more of these follicles to maturity, so we can get more mature eggs out. These medications are given in the form of shots, and it's usually about 8 to 12 days of shots, but we are monitoring you regularly, so as the follicles grow, we're going to adjust your dose. The other medication is called an antagonist, and this is an ovulation blocking medication. So it's also given in the form of a shot, but it allows us to push your ovaries to get those follicles to maturity without ovulating. And then we'll give you a trigger shot, and about 36 hours later, we'll do an egg retrieval. Next slide. One of the common questions I get here is, how safe is it to freeze my eggs? Well, there's risks associated with doing an IVF process, but it's significantly decreased over the years. It's less than 0.4% for mild forms, and the serious complications are even more rare. It's estimated to be about 0.01%, so very rare. And the impact of freezing eggs in the short term seem to be minimal. And in fact, in the longer terms, there's some papers now showing that 4 years out, the eggs seem to do just as well. So we don't think there's a real limit on the duration of frozen eggs. And we also have not seen any increase in birth defects, which is also one of the things that people often ask me if I freeze eggs, is there other sequelae that I need to be worried about? And so the short-term effects we think are minimal at this time, and we don't know all the long-term effects yet. So stay tuned. Next slide. I wanted to overview this process with some pictures. And on the left, you see that first picture is where a woman's given herself a shot. It's just in the abdomen, just under the skin, very easy to give these stimulation drugs, the fertility drugs. Again, they're for about 8 to 12 days. We're monitoring you with these ultrasounds, like the middle slide, where we're actually measuring the follicles and measuring the estrogen that the follicles are producing to see how mature we think the follicles are going to be, so we can trigger you. And then on the right side, that rightmost slide is a schematic of what the retrieval is like. And basically, it's an ultrasound probe with a little needle that goes through a needle guide, and that goes through the vagina and into the ovary, where we drain each of the follicles, and that fluid's collected in a test tube that is passed off to the laboratory. I love what one of my colleagues says, this is the only test tube part of the IVF process. So, you know, the other thing to keep in mind as we're doing IVF is that it's only about a 2-week process from the start of the stimulation to the retrieval, with about 4 to 5 visits for monitoring. When we do that actual egg retrieval, you are asleep for it. So we give you anesthesia, so you can't eat or drink anything the night before, and you should have somebody with you for the first 24 hours afterwards. Then you can return to your regular activities. But keep in mind, those ovaries tend to stay enlarged for about 2 to 3 weeks later. So you may still feel a little bloated, a little bit uncomfortable with those big ovaries, but they do go away after they reduce back down to their normal size after about 2 to 3 weeks. On the day of your egg retrieval, you're going to actually find out the number of eggs that were retrieved, and we'll freeze them on the same day. Next slide. So once you've gone through that egg retrieval process and you get eggs out, maybe 5 or 10 eggs, how many eggs are enough? Is that enough for one cycle, or maybe you got 15 eggs out? Would that be enough? Well, that's really going to depend on what you want. Like, how many babies do you want? And what are you looking for? So the next slide, we're going to talk about the probability of being successful at having at least one live birth, which is on the y-axis. And on the x-axis is the number of mature eggs. And we're only going to be freezing the mature eggs. And the curves that you see, they're different colored curves, and those are really aligning with the age. So you can see the little box of the different ages. So the younger you are, the higher that curve goes up, closer to 100% with the lower number of eggs. So you can see if you got about 10 or 20 eggs and you're younger, you're going to have a high likelihood of being successful with one live birth or more. And as you get older, you're going to need more eggs to be successful. And you can see even that purple slide, that you may never get to 50% or more if you got even 40 eggs, which is a pretty high number of eggs to get out, especially if you're 44 or 43, as you can see the bottom two curves are. So next slide. I also like to use this chart because this chart allows us to look at each age by year and each number of eggs and what your likelihood of being successful at getting at least one live birth. And what I did here is I put some bars in here with the pink circles, and the pink circles each refer to about a 75% chance of being successful at having at least one live birth based on age. So if you're under 35 and you got about 12 eggs, you'd have about a 75% chance of getting at least one live birth. If you're 37, you'd need closer to 20 eggs. And again, as you get older, you're going to need more eggs because there's a higher risk that these are going to be genetically abnormal. So you need closer to 40 eggs, which is if you're 48, then that's a kind of an unrealistic number. So then you have to ask yourself, am I going to be comfortable with a lower percent of being successful? So those are some of the things that we talk about when we're trying to counsel you regarding how many eggs is enough eggs to save for future fertility. We do have additional charts for next slide for looking at what if you want 2 live births, at least 2 live births, or even 3. And this is showing you that if you're less than, or equal to 35, you need closer to 25 eggs, or if you're 37, you'd need maybe closer to 40 eggs. So in a single IVF cycle, we might get, 10 eggs or 20 eggs. It's less likely we're going to get more than that. So you might need a couple of IVF cycles to get the number of eggs that you want if you want to have 2 or 3 live births. And again, we have these probability charts that can tell you what the likelihood of that happening is. Again, at the bottom, it's never equals 100%. So again, these are probability curves. So we're going to try and give you the best likelihood that you're comfortable with, and that's what we use to help guide you. Next slide. So if you've frozen your eggs and you've come back and now you think you're ready to start your family, well, what's going to happen? What are we going to do? And next slide. What we'll first do is we'll meet with you. So you'll meet with me for a consultation, and we'll talk about using your frozen eggs. Now we want to make sure everything's all ready before we thaw those eggs. So we'll want to look at your uterine cavity. And I'll typically do that with what's called a saline infusion sonohystogram. It's basically just putting some water in the uterus, sterile water or sterile saline, and we do an ultrasound just to make sure there aren't any polyps or fibroids or scar tissue or something that would be interfering with your ability to conceive. We have a further discussion about this on our Fertility 101 webinar, again, available on our website at Invita Fertility. The next thing we talk about is what is the source of sperm. So have you found the partner that you want to have a family with, and does he make sperm? So we'll want to get a semen analysis, and we'll typically do infectious disease testing on both of you prior to doing the thawing of the eggs. And so we'll make sure that he would be ready and has the sperm to allow for fertilization. On the other hand, if you choose to be a single mom or have a same-sex partner, you may choose to do donor sperm. And certainly we can get you donor sperm, and then we can use that for inseminating the eggs. The protocol that we use once we've decided that we're going to go forward is a frozen embryo type protocol. So we'll thaw the egg, inseminate it with the sperm, grow the embryo out to about day 5, and then we transfer it. But the key is to make sure that we time the transfer when it's in sync with the endometrium. So the frozen embryo protocols, again, were reviewed in our IVF webinar, and it's basically using some estrogen that we give you, and usually orally, but it could be by patches. And then we just test you once a week until your lining is ready, and then we start a progesterone, and we can transfer the embryo when it's in sync. So we wouldn't thaw the egg, fertilize it, and grow it out until we're ready to do the transfer. And there could be some other testing we want to do depending on what you want. We'll talk about all the different aspects and choices you have. Next slide. So in conclusion, if you're curious about freezing eggs and you want to save your eggs for your future family when you're ready, make an appointment and I'm happy to talk to you about it. There are a lot of other factors that we can consider, and we'll review your history, test your reserve, and discuss the expectations regarding you and what you want individually. It's best to see us before age 37, but not required. We'll talk to you and discuss what your chances are no matter what age you come to see us. But keep in mind, the younger you are, the higher the chance for success. Egg freezing is a great way to offer you a peace of mind so that you can take control of your fertility journey and have a family when you're ready to have a family. So this was a quick overview about the clinical side of the fertility preservation of freezing eggs. And next, I'm going to pass the baton to my colleague, Kelly, who's going to talk to you about the laboratory side of freezing eggs and thawing eggs. Thank you so much. I'll look forward to answering your questions at the end. Kelly, I think you need to turn on your mic.
Yep. Thank you, Dr. Puscheck. So I'm going to talk about what we do in the lab. I will go over the entire lab process from freezing to thawing. The terminology and events might be a little bit confusing. That's okay. We have any questions that you like, they'll be at the end. Just to get started, to let you know that no one other than the embryologists are allowed in the lab. So you really only see us at 2 times, the time of the retrieval, and in the future, the time of your transfer. The next slide. All right, so first things first is a patient is stimulated, like Dr. Puscheck was saying. We're gonna try to make you produce as many eggs as possible. At the time of the retrieval, the embryologist will ask you to state your first name and your last name. That's just to make sure that we identify you. We want to confirm that your name matches all of our paperwork, media dishes, and incubator. So once you are placed under anesthesia, the physician will perform the egg retrieval. The follicles are aspirated into a test tube, which are then placed into the warmer. The embryologist will then take that test tube from the warmer and put it into a petri dish, like you see in the second picture. The petri dish is then placed under a microscope within an incubator, which you see in that third picture. That's pretty much exactly what our incubator looks like. And under that microscope, we can look for the eggs. Once we have found an egg, we will take the egg out and place it into a different dish that contains culture media. After the retrieval and all the oocytes are found, we will then count them and dictate them. And then depending on the time and the lab, your eggs are either stripped at that time or right before the time of freezing, which I'll explain in the next slide. All right, so here's a bit of a better picture for you to visualize what your eggs look like when we're looking for them in that fluid. You can see in picture A, there is an oocyte, and then all around it are cumulus cells. Now those cumulus cells help aid the egg. They're there to protect the egg as well as help it in fertilization. And it does help to direct the egg down the fallopian tube. So how we get rid of those cells is we put it through a series of different sized pipette tips in the solution so that we'll get the bare egg. Now you can see in the second picture to the right, it goes from egg to an embryo, but we're going to just focus on those top 3 photos. There's a GV, an M1, and an M2. Now, just to let you know, we only freeze mature eggs. Now, what's a mature egg? You can see a GV and an M1 are not mature. GV, there's an arrow, and that's how you know that it's a GV. The arrow is pointing to a circle with a little dot in the middle. So, you know, that one's not mature. The M1 does not have a polar body. You just see a round circle. So, you know, that one's not mature. The third photo shows the polar body with the arrow pointing right at that polar body. It's a little circle on top of the egg. Now that is a mature egg, and that's what we will freeze. We only freeze mature eggs because those are the only ones that can be attempted to be fertilized. All right, next slide. All right, so our freezing method. There's 2 different types of freezing methods. There is slow freeze and then there's vitrification. Slow freeze is pretty much non-existent today, and everybody uses vitrification. The problem is with slow freezing is it takes a lot of time and it does form ice crystals. And what happens with ice crystals is they might burst, and there's a potential that the oocyte might not survive. Vitrification is the preferred standard method because they're put through a bunch of cryoprotectants and then plunged into liquid nitrogen. And you can think of it as a glass-like snapshot. And essentially, the molecular rearrangement is arrested. So they're unable to change over time. So the top photo is a basic overview of what's going to happen. We have your egg collection. Then we're going to take that egg and put it through different concentration of cryoprotectants. Once the egg has gone through all those cryoprotectants and is ready, we're going to put it on top of a cryo tip. Well, you can also cryo lock, cryo top. There's many different names for that one. And then that's placed into liquid nitrogen, and it's stored in liquid nitrogen over time. All right, next photo. Sorry. Of course, we're dogs, right? All right. So in this photo, we're going to do freezing step by step. oogocytes are stripped away from their cumulus cells and they're just placed into a petri dish. That petri dish is labeled with their last name, first name, social security number, the name of the media, the date of birth. So we have many different identifiers. Those are also placed in the incubator, which is color-coded and is labeled with the patient's name. So just think about it. We only do one patient at a time. So we'll never do multiple patients. As well as an oogocyte preservation worksheet's filled out, and the patient's color-coded sticker is placed on that worksheet. On that worksheet, we're gonna have the patient's name, date of birth, social security, date of retrieval, an accession number, and there's an accession number that is patient specific. So only that patient will have that accession number, as well as the freeze number. All right, next slide. All right, so here's a picture of basically the apparatus that we're using for the freezing. All right, at the top you can see we have a cane, which that green arrow is pointing to, and in that cane we stick these plastic tubing, and in that plastic tubing then we place the cryolock, which you see on that last picture. And then so all those are needed for the freezing. And on top you can see a little bit, looks like a T. Those are cryotops that we label. That cryotop is what we look at to find in the liquid nitrogen, and it's going to have your last name and that patient specific accession number. On the cryolock device where the embryo, the oogocyte's placed, is going to be your accession number, your last name, first name, and the date of freezing. And then we're going to label it by how many oogocytes. So for example, 1942.1, 1942.2, 1942.3, et cetera, how many oogocytes. Next slide. All right, so where you do write down the time of freezing, that just helps us better understand when you do the thawing, when we are going to do the ICSI, to know what time we can fertilize the oogocytes. All right, and then depending on how many oogocytes you're freezing per straw is how many we can do at one time. So somebody might have a ton of oogocytes retrieved and they're all mature. So we might put 2 on a straw or 1 on a straw. It just depends. It is also facility specific. And then step number 7, we're going to follow our protocol. So the protocol, we're going to place the oogocytes through a couple different cryoprotectants, and then we're going to place it onto a cryotip. All right, so on the picture to the left, it's to better give you a visual understanding of what is happening when we place it in that in the cryoprotectants. You can see before in the ES, the first picture, you see the perfectly round oogocyte with the polar body. And then after 1 minute in our first solution, the ES, it starts to shrivel. And then 2 minutes, 3 minutes, 4 minutes, it's starting to crumb back and fill out. So by 5, 6 minutes, like, okay, the oogocyte's ready to be frozen and put into the VS solution, which is the final solution. And in that solution, all the cryoprotectants are added and the sucrose. So we are able to know that it's ready because it's shriveled. So it's an itty bitty egg looking like a little bit of a potato chip. And we place that on the cryotip of the cryolock. Next slide. All right, so after the oogocytes are frozen, they're plunged into liquid nitrogen. The cryotops are added, and then they're placed into a cane and they're recorded, and to the dewar tanks. They're recorded by the tank and the canister, so that we are able to find you at any time. We can find the oogocytes. Your entire cycle is recorded in our EMR. So just to let you know, we have multiple places that we can look at for your cycle. We have a paper worksheet, our EMR, and a spreadsheet, and the paper worksheets are in different binders within the lab. All right. All right, tanks is everybody's big worry because of the news, like about tanks giving out and failing. But our tanks are a little bit different. They all have electronic monitors. The alarms are hooked up to a phone system, and they're on pretty much a phone tree is the best way to describe it. We'll call our lab director first if the alarm goes off. If he doesn't answer, then the embryologist, then the next embryologist, until somebody comes physically into the lab and turns off that alarm. All right, another thing we do is we manually fill each tank with liquid nitrogen. And we do fill out a daily QC and QA worksheet, and we perform yearly patient checks. So we'll cross-reference your worksheet with the tank and canister, look into the tank and make sure that your cane is in that tank, in that exact spot. All right, next slide. So the Thyroid Protocol, we're essentially doing everything in reverse. Once the oocytes are ready to be used, we can schedule the day for thawing. At the time of thawing, like Dr. Puscheck said, your cycle will be chosen. You'll be able to do a fresh transfer, a frozen transfer, or if you're going to do genetic testing, all the above. Before thawing, we will check all consents needed, and we just have to let the patients know that there is a chance that the oocytes might not survive the thawing process, but it is a very, very low chance. Next slide, please. All right, so before the day of the thaw, we will prep for the media case. There'll be multiple petri dishes, again, with labels. They'll have the last name, first name, social security, date of birth, the name of the media, the date the media was made. They'll have their own individual incubator that's color-coded with the patient's name. All right, then we'll get that worksheet and we will cross-reference and find that patient's cane and the canister. We will double check all the cryo locks. We will look at the accession number, the patient's name, the date of freezing, and it is cross-checked with their paperwork before we do the thaw, because we want to make sure we have the right patient. The thaw is assigned a thawing number, and it is written on a freezing worksheet along with the thawing media lot. Okay. After that, we will follow the thawing protocol. Again, it is put through a series of different solutions to give all of its nutrients and water back. Next slide. And after that, the future is in your hands. Thank you.
Thank you, Kelly, for your presentation. Now I'm going to ask you and Dr. Puscheck some of the questions that have been submitted from people registering for the webinar and then that were sent in during the webinar. So Dr. Puscheck, I'm going to ask you first. Is there an age limit to freezing your eggs?
Well, there's not truly an age limit until, of course, you've gone through menopause, where then you don't really have eggs left. But again, the sooner that you can present and you know that you're ready to freeze eggs, the better. And of course, we'll have to go through that probability slide with you to let you know what the likelihood of how many eggs you're going to need to have the chance that you want to have for a live birth. As you get older, the number of eggs that we're going to be able to get out of you is going to reduce significantly, like I showed you in the two graphs near the beginning. So it's important to keep the age factor in mind, and the sooner you can come to us, the better regarding trying to freeze your eggs so you'll have a successful outcome.
Okay, perfect. And Kelly, let's see, does the quality of the eggs change the longer they are left frozen?
No, they're flash frozen in time, so the quality of the eggs will not change.
Okay, Dr. Puscheck, we just had a question come in. What determines the number of eggs retrieved?
That's a good question. So the number of eggs retrieved really depends on how you stimulate. So as I mentioned, when we're going through the process with IVF, we're giving you the stimulation medications and we're following the ultrasound. The ultrasound have the little follicles as they grow, they're going to make more estrogen. So when we go to the point where we're giving the trigger shot to help mature those follicles and then go to the retrieval, we're draining each of the follicles that are there. So usually you think about one mature follicle is going to have one egg in it. Now, of course, when we're looking at the ultrasound, it's a 2D picture. So we're scanning through the ovary so we can make sure we can get to each follicle, and we'll drain each follicle so we can get out all the eggs that have responded to the stimulation medications. So it's really how you responded to the stimulation medications and the number of follicles that developed that we can drain kind of gives us the idea of how many eggs we're going to be able to get. Now that fluid is sent off to the lab, and the lab actually determines how many eggs are in there. Now sometimes you'll have what looks like a follicle, but when we drain it, we're not getting an egg out. Now sometimes that happens because the egg's still immature, even though it was given the right medications. Other times it's because it's not really a follicle. It looks like one, but it's really a cyst. It doesn't have an egg in it. And it can be difficult to determine the difference between those. But again, we'll drain every follicle that we see when we're doing the egg retrieval. and try and get as many eggs out as we can for you. One of the other questions that sometimes comes about when we talk about this is, will this have an impact on me going through menopause early, or was this going to get rid of all my eggs? What's going to happen here? And it does not. So be rest assured, every month before your period even starts, there's a group of follicles that are designated to grow. And typically with your normal hormones, one will become a dominant one, and that one kind of turns off the other ones. So we're just taking that same group of eggs that would have normally grown and help them grow all together so we can get all of them to maturity, or as many of them as we can to maturity, so we can retrieve them. And no, you won't go through menopause any earlier just because you had an IVF procedure where we retrieved the eggs. So I hope you feel rest assured about that.
Okay, Kelly, I have a question. You mentioned every patient gets an individual accession number. Is that accession number used with every cycle, or does every repeat cycle they do assign them a new accession number?
So every new cycle, they'll get a different accession number. That way we can keep straight which cycle the eggs came from at which time. So every time a patient has an oocyte retrieval and we freeze those eggs, they're assigned an accession number. And then say they have another oocyte retrieval a few months after that, say April, they'll be assigned a new one then. So essentially the answer to your question is they get a new accession number every single egg retrieval.
Okay, and Dr. Puscheck, are frozen embryos preferable to frozen eggs? Would you recommend a patient fertilize her eggs prior to freezing them, or is the quality similar?
That's a great question. So there's many complexities to that, because I'm going to give you a few different answers. So if you have a partner that you want to have a family with, then you may want to freeze embryos. We have a long history of freezing embryos, and we have more information about the short-term and long-term effects of frozen embryos. However, if you are trying to freeze eggs because you don't know, when you want to get pregnant and you're not sure this is the partner you want to have a family with, then you want to freeze those eggs separately. If some patients have said, well, maybe I want to freeze embryos, only just use donor sperm. Well, if you use donor sperm to freeze the eggs, what if your new partner that you want to have a family with later doesn't want to use the embryos that were created from the donor sperm? So a lot of things that we need to think about in doing that. And then the last factor, which is something that we don't always like to think about, but cost is a factor. So if you freeze eggs, it's a lot cheaper than if you are freezing embryos. And the reason for that is that when you're freezing eggs, we're stopping the process right after the retrieval. When you're freezing embryos, we're inseminating the eggs and growing them in culture and then freezing them. So there's a higher cost at the beginning. Of course, when you go to use the eggs later, you'll incur those costs, but you might be able to financially afford that a little bit better later in life. So lots of different things to think about.
Okay, Kelly, you had mentioned in your talk that eggs can be frozen 1 per cryolock or 2 per cryolock. Is one option better than the other as far as the patient is concerned, or is it really only in relation to how many eggs are thawed at a time?
So that one's a little bit complicated because there's so many different situations. It depends. Normally, if you have your egg thaw, some people only want to thaw half the eggs and fertilize half the eggs. In that case, we can do it. It just depends on, we'll pick your number. So if some of the straws have 2 per cryolock and then some have 1, we'll pick the best amount that we can, and we'll probably speak to the patient one-on-one. I would say a majority of the time for our facility, we do freeze 1 per straw. It just makes it, I apologize. I use straws, a little bit of the slang term for cryolock in the lab. So I might use those interchangeably. So more than likely we do 1, but if you have a lot, we'll do 2. And it doesn't really make a difference. It's just we'll help you determine how many number you want for thawing for fertilizing. If you want to thaw all of them, then it doesn't matter how many we freeze per straw. If you only want to thaw half of them, then we got to figure out that number with you to make sure our numbers coordinate with your numbers.
Okay, that makes sense. Thank you. Last question for each of you. Dr. Puscheck, why are some of the eggs that are retrieved immature?
That's a good question. So when we're growing the follicles, not all the follicles are going to respond to the stimulation medication. So we do our best by monitoring you with the estrogen level and the ultrasounds to get a good idea that they are mature. And we know from past experience that when the follicle gets to be a certain size, usually about 16 to 20 millimeters in size, that it has a mature egg in it. But when we're monitoring these, not all of the follicles get to the 16 to 20 millimeter size. So we'll have a group of follicles. We'll go for the majority of follicles that are in that 16 to 20 millimeter size, but there still may be some that are like 12 millimeters. And we'll drain those because sometimes we're surprised and find a mature egg in it, but those are more likely to have an immature egg, either a GB or an M1 in it. But we can't push you further so that all those follicles are mature, because as we go further into the stimulation, the follicles get bigger still, and if they get to be 22 millimeters or bigger in size, they're more likely to be post-mature, and then those are eggs that aren't going to fertilize very well either. So we do our best to get the largest group of follicles in that 16 to 20 millimeter size before we trigger you, so we'll have the greatest likelihood of mature eggs. And it's often very common to see one or two or a couple that are immature, either the M1 or the GB, and that's just part of it.
Okay, I lied. I'm actually going to ask you two parts and
Okay.
then get to Kelly, because I think this one question is important. I don't want to skip over it. Someone had asked, is it wise to freeze if I only get one egg from my retrieval?
Yes. I mean, you always want to freeze. You never know the possibility that one might fertilize, and that might be your one baby. Sometimes all you need is one. I would definitely go for it. You didn't go through.
I think that's very, very wise. I mean, if we've gone through that whole stimulation process and only got one egg, again, freeze it, because if you go through another stimulation, you might not even get an egg. So, why is it that you only got one egg? It's usually because the ovarian reserve is not great. So we can certainly try other stimulation protocols to try to improve that, but you might not get any more than the one egg. So freeze it. And yes, we've had people with one egg have a live birth. So it can happen. I agree with Kelly on that 100%.
Okay, Kelly, last question. Can you tell us what is different in our tank system from the clinics that have had failures which resulted in thawing of tissue that was then destroyed?
Yeah, so those tanks, from what I understood, from what I read, a lot of them were on electronic monitoring system that the employees didn't have to keep going and checking, and it manually filled the tanks up with liquid nitrogen. So in a way that the system failed, it never made an alarm come off when the liquid nitrogen got low, so they were not aware. So ours are different because we're on an electronic system as well with that phone tree, but we manually fill our tanks every day. Well, not every day, but pretty much a majority of the days with liquid nitrogen, and we fill each one up to the top every week. And just to let you know, we're there every day in the lab. So 7 days a week, there's always someone there, no matter what, even if they're in there for 2 hours, 1 hour, or all day, holidays included. Someone's always going to check on the status of the tanks. They'll be stepping foot.
Okay, perfect. I'm going to post one more poll for our attendees. And it's, do you feel like you have learned anything from this webinar that you didn't know prior to watching it? Okay, I'm going to share these results. They were all yeses, so good job. me just close this off. So thank you so much for attending this webinar and for sharing your responses with us. Thank you also to Dr. Puscheck and for Kelly Schorsch for sharing this information with us. Please check out our website at inviafertility.com for dates of future webinars, as well as recordings of our previous webinars. Please also follow us on Facebook and Instagram for updates about our practice. If you have a question that we didn't get to, or if you think of something tonight after this kind of sinks in and you want to ask it, please feel free to email it to info@inviafertility.com. Stay safe and healthy, and thank you for attending.
Thank you.
Thank you.